Hello, everybody. Great to see you for our second part of Translational Teamwork Series 2026. For those folks who are just joining us at this series, I'll give you a quick overview of what other resources and opportunities are available for you. And if you're interested in watching what you missed, everything's recorded. So here, these are specific workshops, and you should have this information in the chat as well about topics related to teamwork, including micro-credentials, workshop series, and previous topics. Our team includes myself. I'm Ekaterina Noyes. I'm a faculty in the School of Nursing and in the Department of Surgery in the Jacobs School of Medicine. And I have two excellent assistants with me. So Liz Burgett is a translational team science specialist. Catherine Sidota is a workforce development specialist. So they can answer your questions, and you most likely will get emails from them about post-workshop survey, other courses and materials, certificates, etc. So if you see email from one of those ladies, you got to read it. So you can find information about all workforce development series sponsored by CTSI on the CTSI website. So here we are at the bottom. This year's series includes 3 installments. So last month we met with Dr. Jill Sissick and talk about administrative teams that support research teams. Today, we're going to talk with Dr. Sharon Hewner, who is a professor in the School of Nursing, and we'll talk about teams that collaborate with clinical and non-clinical community partners and involve both humans and technology innovations. And then next month, we'll have our third and last presenter, Dr. Gloria Aidu-Frimpong, who is a faculty in the School of Public Health, and she will talk about international teams and teams that work on very sensitive topics like HIV, intimate partner violence, and other interesting topics, and how to stay open and maintain trustworthy relationships. So if I mention every time that we're going to talk about teams, because I love teams, I work in teams, but that doesn't mean that every one of your research projects should have team. So it's totally acceptable to work alone. Many of us are much more productive and can finish work quicker. But there are certain topics, the ones that we're discussing today and in this series, that require teams. And so while there's no pressure, it's useful to know how to build teams and how to work with teams when you need them. In addition, we're going to be touching on other topics. So the focus of this series is specifically on teamwork, logistics of teamwork, principles of teamwork, psychology of teams. So it's not focused on science. We're not going to talk about nursing. We're not going to talk about IT technology and community engagement, but we have other workshop series that go in depth on those topics, and many of them listed here on the slides, and you can find them on CTSI website. If you're interested, and if you complete all 3 workshops in this series, you can reach out to Liz and receive a certificate of completion. If you're interested in micro-credential in translational teamwork, please reach out to Catherine. She will enroll you and provide additional assignments and deliverables that you will need to do to receive a micro-credential. Those of you who are clinicians and would like a CME credit, you can also get 1.5 credit for this workshop. And Catherine can also share with you information that you need to complete to get that. Okay. Also, this series this year is about specific applications. So the foundational principles of teamwork were taught in 2023. And all of those workshops have been recorded and available on CTSI YouTube channel. So if at any point you want to go back and rewatch some foundational principles of teamwork, you could do that at any time free of charge. And there are many more other topics there as well, in case you didn't know. All right, so we're ready for today. Any questions at this point? I don't see anything else other than my screen, so if there are questions, please let me know.
Okay, there's no questions in the chat at this point.
All right, fantastic. Okay, so our guest today is Dr. Sharon Hewner, who is a professor of School of Nursing, and her PhD is actually in medical anthropology. And she has a very interesting career working both clinically as well as in healthcare delivery and insurance, and a lot of the work on using data way before we had words like AI and information technology and machine learning, how to use data to improve efficiency, specifically on nursing care, how to improve patient outcomes, improve access and reach. And Sharon had a distinguished career working on those topics before they became fashionable. So today, unfortunately, we're not going to hear from Sharon about her interesting work. I met with her a couple of months ago and recorded an interview that is available to you in its full entirety. If you registered for this workshop, you should receive a link to the full interview. But today, we're going to just re-listen to specific cuts from experience and wisdom that Sharon shared with me and map it to foundational principles and specific strategies that work very well in these settings of socio-technical innovation, using data and technology to improve healthcare delivery processes and improving patient outcomes. And hopefully you can learn from Sharon's experience and perhaps find some strategies that could support and enhance your teams. Welcome, Sharon, and thank you very much for being here with us and for sharing your experience with me.
Thank you. I really appreciate the opportunity.
All right. So we have two objectives, and those are important because you'll receive an evaluation form from Liz after the class, and hopefully I will be able to address those objectives in our presentation today. If at any point you have any questions, please interrupt, raise your hands. It's not a very large group, so you can probably speak up and I will hear you. But the objectives are, first, to understand pros and cons of different unique strategies of building and managing this kind of very diverse teams that include academic and non-academic stakeholders, and also clinical and non-clinical stakeholders. So typically we just focus on academic and non-academic, but in this setting, it's also important to recognize that there are clinicians and non-clinicians who are involved in developing socio-technical innovations. So you're surrounded by people who speak very different languages, have very different expertise, different work processes, different expectations. And so that creates very rich research project, but very complex environment to work in and to lead, especially if you're working on a tight budget. And in this case, it was a HRQ funded grant. And this is the first and only grant I can admit that Sharon managed to complete in time and on budget without no cost extension or any other limitations. So I'm very, very impressed and want to learn about that another time. And the second objective for today is about adaptation. And I thought it was very important to talk about it. And this particular study was a great illustration that most of us who have done studies know that it doesn't matter how good and smart your proposal is, at some point you'll have to change things. And those changes become especially important and critical when you're working with real healthcare organizations, because you can stop delivery of healthcare services. It's not like you have a lab experiment where you can repeat, reorder the same animals, control for other external factors. When we study healthcare and healthcare providers, the real healthcare process is going on. And so regardless of the grant, regardless of the funding, you can't stop that process. And that process interferes with your research findings. And so the only way we learn to deal with it is to know when to adapt. But that also creates a lot of challenges to validity of your study. So how can you prove that you're still doing the study you proposed if your partners are different and your environment is different? And the second objective of our today's discussion is how to make those necessary adaptations and how to know when those adaptations are necessary. So those are the two things I want to focus on today. Any questions at this point?
No questions in chat.
All right, fantastic. So I'll tell you a little bit about the project first. So you have some kind of background, but again, this is not a research talk, and there are several papers that Sharon and her team have published. So if you want to learn specifically about personalized cross-sectional translational care management, there's another information. But for the purpose of today, we'll focus specifically on the teamwork that was put in place to make to start this project, to do the necessary research, and to achieve the deliverables and objectives. All right.
I think that for me, working very closely with Healthy Link and all of the partners that they have, so I also sit on an advisory board at Healthy Link, and just being able to listen to what kinds of issues are coming in to them, and really thinking about how do we blend what we're doing here at the university with what they're doing. So not trying to take it over, which I think sometimes it can happen. I think with the proprietary electronic health records, I think they kind of own things and then you can't change them and you can't modify them. But to me, it's the flexibility that you can get by working closely with a partnering organization to really customize to what's happening in your region. What are the problems that you have there? And I think that we, at least right now with AHRQ being sort of on the shelf right now, really thinking about how do we build with these community partners and offer our suggestions and get their help.
So Healthy Link, the Health Information Exchange organization here in Western New York, was one of the partners for this project. They house medical records from all participating providers in the region. And the idea of the project was to utilize this large pool of data and abstract very specific actionable information that providers can use to accelerate referrals and care delivery for complex patients with social and medical and behavioral needs who get discharged from the hospital. That's an overview of the project. The reason I chose this quote is because for many of us who work with community partners, we conceive our ideas as academics. You work in the office, you read an interesting paper, you went to a conference, says, oh, this is a great idea, I can do that. You write your proposal, and then a couple of weeks before the proposal is due, you said, oh, I need a letter from community partners. Let me find somebody who can give me quickly a letter. And then we hear from those folks and says, oh, the team didn't work, the partners didn't participate, or they promised and never delivered, and then they disappeared. And we're trying to fix this problem backwards. We're trying to force this partnership, while in reality, the best approach to build partnerships with community stakeholders is to start with the questions and challenges that are important to the stakeholders. So I thought that quote from Sharon was really, really instrumental in understanding why some partnerships work and lead to revolutionary innovation, and other partnership, you can't really get them off the ground, and sometimes can't even get the letters on time, and then it kind of fizzles out and nothing happens. So I want to emphasize that this is one of the first strategies when we talk about teamwork, is to find a topic that unites you and your partners, not to trying to convince them and twist their arms to join you on your project, but start with something that's already important and relevant for them. And so this is a second quote that emphasizes the same principle by engaging stakeholders, by adding value, not only picking a topic that's important to them, but also building your aims and your deliverables around the value to stakeholders, not to me in my professional career, not to my tenure, but to the stakeholders' objectives and priorities?
I think that the basic principle of trying to make things easier for the provider is really foundational, right? If we can just think about what are we trying to accomplish and how could we make that work more smoothly? Most times in clinical practices, people are really good about coming up with fixes, like a short-term fix to whatever the problem is. And you get these things and you then have this extraordinarily complex system. And it's like, this is relatively simple. If we could just give you the information that you need to make a phone call so you don't have to spend an hour trying to find from all of these different sources the same information, then we've made your job a lot easier. We've made care better. We've improved patient outcomes without you really feeling any pain at all outside of the initial implementation. I think that.
Okay. All right. So let's look at this diagram and to help us understand what was happening and where the project was happening. So there are two partners. So there are clinical partners, which are primary care practices, behavioral health, and social services that provide care to a lot of the same patients that have medical, behavioral, and social care needs. And then Healthy Link owns the data from these partners and hospitals where these patients get admitted. So the project starts by the agreement between primary care and Healthy Link to identify a list of what we call high-need patients. So that's a technology innovation. That there are very little humans here, but to get understanding what are the high-risk patients, and high-risk here are patients for risk of readmission because they didn't get, after discharge, they didn't get the care they need, they develop complications, and they go back to the hospital. So we know ahead of time who they are. And when any of the people on this list get discharged from the hospital, the algorithm get activated, and we see, okay, is it the patient we're looking for that we know have high needs? If yes, then based on data that Healthy Link already has about those patients from the hospital, enhanced transitional care alert is generated. If not, nothing happens. Those people go home. So what is this enhanced transitional care alert? So this is another technology innovation. Dr. Hewner worked with computer scientists and human factors engineers and clinicians to identify from many, many pages of hospital discharge that includes all sorts of notes, services, diagnoses, all sorts of care that happen in the hospital, identify critical lists, no more than one page, of what are the most important care needs of these patients between discharge and this first week or 48 hours after discharge. Do they need housing? Do they need transportation? Do they need food, medication? Do they have a primary care? So that when the transition care nurse will receive this alert in the morning, she knows exactly what to do. She doesn't need to dig for it. She doesn't need to pull multiple medical records from different computer portals. She has a half-page alert with the phone numbers of providers and content information, and can very quickly and effectively do the steps that you need to do. So that's when it becomes a social intervention. So now the technology was used to provide the summary, but now people have to act around it. So for nurses who primarily work in primary care settings, but also care coordinators from behavioral and social services, in order to effectively use this care alert, they probably need to change their workflow. So they need to know to look for the alert. They need to coordinate with Healthy Link and give them a roster of their high-need patients. And they need to be prepared to act on that alert. So there has to be a person who is assigned to this task every day of the week, regardless. It could be the same person, it could be a different person, but somebody who is looking for the alert. So that's, in a nutshell, is the project. The behavioral component, the behavior change component for the providers, and the technology change using data and using the kind of information, changing the kind of information that's shared between providers and the timing of this information. Sharon, anything I missed? Anything important?
No, I think that gives a pretty good sense of what's happening. I mean, one of the things that we did provide in the alert is she can access the information at Healthy Link. So pieces of information that Healthy Link may have that may not have gotten to primary care, she can take a look at. So she might look at x-ray reports. So she can sort of pull some of that additional information, but it's one source instead of trying to wait for the discharge summary to come, which often it can take up to 2 weeks to get to primary care. So.
Okay. All right. Any questions? So obviously not everybody on the call is a clinician, and we're not going into depth about what kind of conditions these people may have, but it's timeliness of information, burden on coordinating team, and the prevention mechanism that if you act quickly and give patients the care that they need right away, you can prevent readmissions and complications and other adverse events down the road. So this intervention is aimed to address all of those components. Okay. And of course, on top of that, sort of covering all of this complex flow chart is the research team. So let's hear about the team.
So I think I'll start talking first about our partners to give some context for where we're trying to work. So my work is focused in federally qualified health centers. They offer a wide range of care, including maternal health, pediatrics, general medicine, in high-need populations or rural areas. There's a number of them across the A County region of Western New York. So I am working specifically with Jericho Road, and the other clinical practice sites that we're working in are Spectrum Health and Behavioral Services, because we were really interested in people who have both physical healthcare needs and also mental health care needs. And then I've also been working with the Buffalo City Mission, looking at people who have extremely high social needs. And much of the work that I do is sort of propelled by the health information exchange that's shared with Healthy Link, which is a regional health information organization here in Western New York. The research team is also very diverse. We have PhD prepared faculty, doctoral students, administrative support, and we represent the professions of nursing, social work, physical therapy, implementation science, industrial and systems engineering, and computer science engineering. And Dr. Noyes is part of our team. The team itself, though, that broad team, is divided into two sections that overlap a lot. But the two sections are, one is really dealing with the technical aspects and the data analysis phase of things. And then the other team really forms what I would call our implementation resource team. I would be the leader of that. And then we have people who are expertise in implementation science, that's Dr. Noyes. Systems engineering is Dr. Sabrina Casucci from Industrial and Systems Engineering. Social work is Dr. Elizabeth Bowens. And we also have a project coordinator who's really integral to this whole process as far as making the outreach calls and getting consents and doing all of those kinds of things. And then PhD students in nursing who are largely involved in direct data collection and working directly with the practices. That's the team. How do we work together is another question.
So I would like you to think about this strategy. So we're not simply partnering with organizations. We including members of those organizations as investigators on the research team. So that's the difference. Very often we get letters from the community organization that says, yep, we're collaborating with them. While in reality, there's no bi-directional relationship. They provided us support. Maybe they'll give us data. Maybe they'll review a manuscript when we're ready. but it's a very different type of engagement. It's not really a teamwork, the kind of teamwork we're talking about. So on this project, we actually, Dr. Hewner, identify individuals in each organization that were involved in research meetings, planning, interactions, data collection, and outcomes interpretation. So we'll summarize the partners. So the primary care practice was Jericho Road, Behavioral Services Spectrum, Buffalo City Mission is a homeless shelter, Healthy Link is our clinical exchange. And then the folks and the discipline that contributed to this team are listed here. So how did it actually work? Okay, let's...
I think that we definitely knew that we needed to have the technical expertise on how to just move information from one place to another. And so Dr. Casucci would have been working directly with the sort of database managers in all of the clinical sites, and also then with Healthy Link on how do we get information back and forth and how do we make this a really efficient process. We needed to bring in additional expertise on social need and homelessness, which is where Dr. Bones came in, and she's been working really intensively with our students who are interviewing and being on site with all of the different patients and providers that we work with. The work with providers, that's really something that I led. We worked very closely with a PhD student who sat in on all of our meetings. We had all of the transcripts of those meetings. They did specific interviews, and then they analyzed those interviews. So we really worked intensively in thinking about how is that implementation team working together and how do they feel about the whole process. We included the research team as part of that. And the central piece of the whole project is sort of this health information exchange that creates electronic enhanced care alerts that go out to the primary care practice at the time when patients are discharged from the hospital.
Okay. So if you listen carefully to what Dr. Hewner is saying, that she is very strategic in designing not only identifying people on a team, but creating the workflow for efficiency. Because again, when you work with such a complex teams in many community settings with different expertise across different settings, it's very easy for information to get lost. Some people will get bombarded with emails. Other people may get left out of the project for several months or years. So strategically thinking about efficiency of teamwork, this is one thing that was unique about this project. And that's probably one of the key factors that made it so successful, because the teamwork was not afterthought. It was intentional and it was planned. So let's see. So, if you ever heard anything about teams, so you've heard about forming, storming, norming, performing, right? We kind of take it for granted. Yeah, grant is funded. These people were listed as investigators. Let's go straight to work. And you can do that when you have 2 or 3 people around the table and you're in the same department. But when you start driving around town, and some people have clinical schedules, some people have different EMR, this become increasingly more and more complex. In order to conceptualize this work, before we even started the project, sort of this was the model of the team that Dr. Hewner was talking about before. So we have the technical part of the team, folks in biostatistics and machine learning and algorithm developments that were working on the algorithm, and folks who are more clinically focused, who were on site providing care, understanding risk factors, and identifying workflow processes that need improvement so that we can effectively integrate data. So the interesting component of so if you try to schedule meetings for everybody, there's probably easily 20 people here, your weekly meetings with this team, you quickly run out of time, right? You will never meet. So when we thought about it, so Dr. Hewner created this very interesting model. So she will meet with everybody whenever she can. I don't know when she sleeps. But so each team will meet separately for working meetings, but periodically, quarterly and annually, the whole team will come together in a more informative, I don't want to say team building. It was not really about team, but understanding each other priority. Because if you think about it, so we're building data algorithms here, these folks, that these people need to use. So you can't simply build an algorithm for somebody to use without getting feedback directly from the people who are going to use it. So even though by the expertise, the teams are separated by the expertise, they're still dependent on each other because the technology folks need clinical information to build the appropriate algorithm. And clinical folks need to give technical people a feedback on how they're going to use the algorithm, how much information they need, how do they make decisions, so that both sides understand the other team requirements and limitations. And it was a very interesting process, and we created different modalities for interaction. Sharon, do you want to add anything here, or any particular word of wisdom, how you came up with this plan?
So I think that part of it was just the logistics of trying to figure out how can I have a meeting which is appropriate for the people who are there, right? So really kind of dividing how we thought about pieces. The other thing that I think is important is that we really built in a lot of flexibility in the meetings. And during the course of the 5 years of the study, they actually have changed and evolved. So we don't necessarily meet in exactly the same teams that we did at the start. There's a lot more focused stuff on one particular practice and what's going on at their practice. There's not necessarily the same integration, because now we're talking about what results did you get and how do your results inform my results in this other part of the study. We're also, I think one of the things that we are working on right now is trying to figure out how to adjourn and how to pull together a meeting of everybody that is meaningful for them. And we've had a couple of planning meetings to sort of think about how do we take 20 people and bring them into a room for a couple of hours and really make that relevant to them and to thinking about how do we sustain the project going forward. So it's been an interesting process. It hasn't been boring.
For sure. So for those of you who have never worked on those on this kind of large cross-disciplinary teams before, you said this is common sense, right? That makes sense. This is how you're supposed to do it. Those of you who worked on teams before know that very often it's a small part of the team that meets periodically, maybe PI and a postdoc, or PI and a project manager, and everybody else gets a quarterly report, maybe, and biostatistician may not hear from the team at all, because what's there for biostatistician to do until the data are collected? But the challenge is that by the time data are collected, there's nothing you can change anymore. And if you missed important data, or if you didn't collect it in the right format, or didn't store it in the right setting, there's nothing this biostatistician can do to correct. They can only deal with the data sets that's been given to them. So this model of parallel, loose kind of communication and configuration allowed for the feedback to occur in this project across all different stages. Early on, when the machine learning algorithm was developed, the clinicians were able to provide feedbacks. When we tested the workflow and observed how nurse care coordinators actually uses the data and what's useful and not useful and how long it takes and how easy it is. The engineers observed the process and reviewed the information so they could see where their algorithm can be improved. And so this logistical complexity creates a great opportunity for meaningful research and for constant innovation, that doing it in a simple way, you do here, will not be sufficient to address this level of problem. And so we know that this is one of the main reasons researchers work in cross-disciplinary, multidisciplinary teams, because the challenges that they're trying to solve are not the simple challenges. It's not that you need 3 investigators because there is so much work to do. It's that you need 3 investigators with complementary expertise, because it's not just the nursing project. It's not just the machine learning projects. You need to bring all of those experts in the room together, that they can hear from each other and exchange their expertise. Any questions at this point for me or for Dr. Hewner?
There are no questions in chat.
Okay, very good. All right, moving on. So, and of course, when we wrote it in the proposal, we said, well, here is on the left in blue, here's how technology is going to be developed. We'll assess factors, we'll plan, we test, and we implement. And on the right in pink, this is how a team is going to form. So if we bring the right people, we'll storm the norm and we'll perform. Very straightforward, right? And so this is what actually happened. So the algorithm, as expected, didn't work many times. And so the data science team will have to go back and figure out, is it the data that's not working? Are we not getting the accurate data? Sometimes it was about the data. Sometimes it was that the team was not implementing the information that was shared with them for different reasons. It also turned out that what we thought was going to be one team forming, storming, performing, it turns out that the 3 partners evolved at their own pace. So each of the community sites were undergoing their own team changes. The staff was changing, the environment was changing, the market competition was changing. So there are other actors that entered the primary care market and other insurance products, so that the primary care practice had to address other requirements and practice changes that were enforced by other groups. So at the end of the day, there were multiple team forming activities going on. And what Sharon mentioned is the implementation resource team. That was the core research team that was keeping track of those multiple changes and making strategic decision when it's okay to continue with the planned protocol, and when we need to stop and make strategic adaptation to that protocol, because we can no longer continue with the process as planned. And so that implementation resource team, we call it failure to rescue team. So if you can't wait until the end of the project that says, oh, sorry, it didn't work, we got to start over again, your funding is gone and your grant project is over. So it required a lot of judgment and continuous surveillance to make those strategic stops and says, no, we need to revise a plan. We can't wait for the things to evolve naturally, or they're not evolving in the right direction. So that was turned out to be the most interesting part of the study, interesting to me as an implementation researcher, to understand this issue of adaptation of the protocol, adaptation to changing environment conditions, adaptation to changing team compositions. And the very simple change were the graduate students who at some point graduate and they leave. And then you have to decide, am I going to bring the new graduate student to the team and train them from the beginning? Or do I continue working with a student who graduated but in a different capacity? So even these kind of decisions could significantly change the duration and efficiency of the research protocol. So the other thing that we discovered is that even though colloquially we keep saying, well, it's a research team, it's impossible to ignore that there are actually sub-teams working within that large AHRQ-funded project team. And that is consistent with the evidence. So some of you may have seen this. It's a book, actually, Team of Teams, The New Rules of Engagement in Complex World, that was written by Army General Stanley McChrystal, based on his experience managing complex military teams, that if directions are very clear and the management is bidirectional, here is the general, here are the lieutenants, here are the soldiers on the ground, you tell them what to do, they follow your direction. You can operate it that way. But when we're talking about research teams, the information is not one directional, it becomes bidirectional. And the reports from the ground may impact the process and timeliness of deliverables and perhaps even the strategy of how the project is going to continue. So it requires this much more flexible, integrated management approach, which is called Team of Teams. So let's hear about that.
So I really loved the interviews that we did with providers. It was a very simple interview, 6 questions, basically. So tell me how you think the projects are going, what's going well, what's not going so well, all this kind of stuff. And we asked them every 6 months across the course of the research. And so they really were minimally invasive for people. And you could just really see how things changed over time. But what was interesting is the process was changing asynchronously. So at the beginning of the project, we're working intensively with the health information exchange and with the primary care, looking at their data to try and see where we could work with things. And there was much less role for the behavioral health team, and the city mission was almost completely outside of that process. And so what we had to do is sort of engage everybody up front at a very high level. So we had a number of workshops where we brought all sorts of people from these different organizations in for Zoom meetings because it was the pandemic. And they got a chance to sort of see the other perspective, even though they weren't currently going to be involved. And what happened was that it was a struggle the first time we implemented this at the primary care practice. There's no question about that. But when we went to implement it at the second practice, it was like super easy. I mean, it was no big deal. We turned on the alerts. We figured out that there was one thing that was causing a problem. We fixed that one thing, and they went ahead, and it's like it's been running seamlessly ever since then. But it was weird because the whole time when we're doing these interviews, they're saying, well, we don't understand what this is going to do. And I don't think it's going to make any difference. And this is so weird. I don't know why we're having these interviews all the time. And that was the kind of feedback you were getting. And then all of a sudden it's like, wow, this really helps us. We love this, and it really saves the nurses time. And it's so much more efficient. And it's like, okay, great, wonderful. Thank you so much for that feedback. But yeah, it's hard for them to visualize the difference it could make. But keeping them involved and letting them see that other organizations were struggling along the way, I think was also really helpful for them as far as implementing it themselves, because they could sort of think ahead of how they were going to arrange getting the phone calls to the right nurses, right? How are they going to manage that, and how would it work with their electronic health record? So it was fun. It is fun.
All right. Any questions at this point for Dr. Hewner or me? Any clarifications? Dragging along? Okay. All right. So, we talked about the process. So we didn't really have one team, right? We realized that we need to allow enough flexibility so individual organization and individual teams can progress at their own pace while watching how the other members, how other sub-teams are progressing, sometimes a little bit ahead of them, sometimes a little bit behind. So how did they communicate? How did they keep us involved and keep each other involved? So let's hear from that.
It's the multiple different touch points that helped. We had formal meetings, we had workshops, we had quick phone calls. We had these student interviews being done. We also worked very closely with the patient population. But I felt that was outside of the realm of what our main scope was. here.
Okay. So these different modalities of communication turned out to be very useful. And as Dr. Hewner was saying very often early in a project, the partners are saying, why are you asking me this? I'm not doing anything. Why am I even involved? I'm wasting my time on the call. I'm listening to you. And you had to sort of struggle for this resistance and say, trust me, it will all make sense. And then it does, right? So again, this illustrates a point that very often people assume that teamwork means you agree on everything and you have this collegial world peace situation and everything's hunky-dory. But effective teamwork is not always agreeing and being on the same page. It very often involves conflicts and disagreements, and mirroring that and demonstrating that and allow for the disagreements to evolve organically or for the information to be shared can actually help partners to eventually gel over time. So if we look at our usual normal storming performing, the storming may be happening even in later phases. You don't stop norming and storming. You don't always, I should say, that the evolution of a team may continue over time, especially in a highly flexible environment where we actually lost and then regained some of the team members that were rehired or promoted in different roles in these organizations.
I think one of the things.
Okay.
Sorry, let me just
go ahead.
I think one of the things that was really important as we went through and kept working with the teams over time is continually reminding them what everyone's common goal was, right? So even when they're doing something completely different, it's like, remember, we're trying to make it a lot better to care for these very complex patients that are taking everyone so much time and so much resources in your primary care practice. The goal here is to really make that care better. And that reminder probably occurred in almost every meeting across all the research team groups, all the primary care groups, wherever we were. It was constantly keeping that here's why we're here. We're doing this because we really care about taking care of these patients. And that was helpful, I think, to keep people really focused, even when it didn't seem like it was the most important thing. So.
Yeah, thank you for highlighting that, Dr. Hewner. And so if we think of the 7 C's of a teamwork, so what we just watched, the episode is about communication, but it's really the cognition, the shared mental model, the shared vision and priorities that kept people communicating together and force them sort of to, if you're not understanding, why am I not understanding? Why am I investing my time? It's because we have a shared model. So I'm going to pause here. So I shared with you, I think, 7 strategies for keeping teamwork going. And I would like an opportunity to summarize and reflect. So out of the strategies that we discussed, and you're going to have a slide, so you don't need to look at this right now, but based on what you remember, which strategy do you think works the best for monitoring team performance and maintaining team communication in this kind of complex cross-sector environment? Liz, can you please walk people through the tool?
Yes, so you can either scan the QR code that's on the screen and it will bring you to the question where you select whatever answer you think is correct, or you can use the link that I pasted in the chat and do it on your computer.
And so the options are the strategies, interviewing team members about the perception of the team progress, and then incorporating and sort of clarifying the things that are not clear or misunderstood, scheduling regular team check-ins to discuss progress and challenges, and again, to use that as an opportunity to clarify the shared model, to communicate again, and to allow people to learn from the challenges and anticipate those challenges. Analyze transcript of the team meetings. So keep the transcript of the team meetings and then analyze them to see sort of where you're progressing and why you need to make changes or why the process didn't go as planned. Using ad hoc phone calls and huddles to address protocol deviation with specific partners and all of the above. So it's we have 9 people. I don't know if anybody else wants to respond, but the answer is pretty clear that all of the above actually may be needed to keep a project of this magnitude going. And having those multiple options can really give you a various perspective on the information and on the insights, because not everybody is sharing information the same way and not everybody's seeing the same things. So the research partners, the technology partners, the patient partners may all have very different perspective at different time. So having those tools available and using them throughout could be very, very useful. And then remembering why you actually made the change when you're ready to write the progress report. Why is it that we didn't continue with that strategy? Or because those things had happened and we are no longer able to continue with the recruitment or facilities or whatever that was. Okay. All right. So ready to move to the objective number 2? Any questions about the strategies, pros and cons of different strategies? And unfortunately, there's no one strategy that fits all, right? It's not one strategy that could work every time and not one strategy that can work for all sorts of partners and all sorts of problems. So our objective number 2 was to specifically understand when is the right time to adapt. So not to compromise fidelity of the protocol, but to adapt to preserve the shared goal or preserve the teamwork, or to improve the chances of implementation to succeed, as it was in this case. So this tension between fidelity versus adaptation and survival or sustainability. Okay.
When we did interviews with people, all of the different participants, they were like, this is never going to work. This is so crazy. It's going to take all of these resources and it's really going to be very problematic. And so we had multiple meetings where we would sit down and say, well, okay, here's one piece that we need. How can we do this? And we just broke it down into one little piece, one little piece, one little piece.
Okay. So this is one strategy that can work in your personal life, but it works very well with complex changes like
when we did.
So in the grant protocol, we write it as, okay, we're going to move one step at a time. We're going to solve all of the pre-implementation problem. We're going to design the prototype and we're going to involve the partners. We're going to test it. In reality, each of those steps ended up being a series of small sub-steps. And instead of doing them all at once, we were doing one thing at a time, then add another step and go through the same cycle again. Oops. And then agree that, okay, now we can make change in algorithm. And now we can make a change in how we receive the data. And now we're going to make a change in the workflow. And sort of adding those small but manageable pieces, one step at a time, improved, first of all, improved willingness to change. Because if you show people a very big gap between where we now and where we want to be at the end, the fear or overwhelmed reaction that, oh my God, I can never do that, that can just paralyze the process and completely compromise willingness to change or willingness to partner. So the brilliant strategy here was to not get bogged down by unwillingness of people to accept, and in this case, we're talking specifically about community partners, to accept and commit to the entire transformation, but start by agreeing to, okay, we'll be happy if you work on the algorithm with us, look, algorithm worked. It's interesting. Do you want to implement it? Let's just implement it and see what happens. It worked. Let's work on communication. So how are we going to send this information to other partners? And so thinking about it strategically again, and this is the difference between what we write in the grant protocol to the funder versus how we actually design and implement the study with a complex team over time. That gives you a realistic view of how to stay true to the proposal and hypothesis testing without losing the partnership and losing the morale.
There were challenges on the technical side.
All right, sorry. Skipping. So let's hear.
There were challenges on the technical side, and there were challenges on the social side as well. So while we were working with the practice, they had major turnover in the practice at one point. That really meant we had to sort of step back, try to be really supportive, try to think about ways to make the process easier for them to get over that hump. And I think a lot of it was developing trust with them. How do we make it possible for you to do really good work without sounding like we were criticizing what they were doing? And I think many times in the meetings that we were involved with, I would say, you guys are the experts on how to do transitional care. All I'm asking you is, how can I make your job easier? How can I present you with the information that you need to do a better job? And how can I make sure that it's accessible and it's going to take you less time and that you're talking to the right patients?
So this, I thought, was a fascinating strategy that Dr. Hewner had used on really how to provide feedback to your community partners. Because let's admit it, at the end of the day, they didn't ask us to do a research project with them. We identified that they had a problem. We wanted to build the research interventions. At the end of the day, it's a research organization that drives the innovation, particularly in this case. So while they're our partners in this, they don't necessarily share the blame for things are not working. And using this framework of sort of, it's not your fault, it's not working, but tell us what's not working and we'll work with you and make it better, I thought in this case was a very, very efficient strategy to keep the partners engaged, not to let them sort of fall apart, being overwhelmed that their normal reality, the most inefficient reality that they use is still their normal reality, right? It's change that's difficult. And Sharon shared with us examples that a lot, so these are nurses who work from home during COVID. And so here they at home on kitchen table, she's looking up something on her phone, looking at her computer where the medical records are, trying to call somebody else to coordinate. It's completely inefficient, but this is how she's been doing it for the last 5 years. And convincing this nurse to change, it's actually, even though we're promising her a smooth and efficient and quick experience, there is a natural resistance because people assume that change means I'm doing something wrong. So understanding this psychological perspective and helping people understand that no, you are not wrong, even though there's a better way of doing this, that's what requires, I think, a lot of maturity, and that's what requires a lot of leadership on those research teams, understanding where your partners are coming from. They don't want to appear incompetent. They don't want to, most of the time, they don't want to admit that there is a better way of doing it. I think it's the same thing. If you try to tell your partners that there's a better way of doing dishes, you'll get the same reaction that don't teach me how to do dishes. I know how to do it. So, but here, I think as a researchers, we see the benefit of innovation while our partners may or may not see the benefit of innovation until they see it. And then, of course, they're very excited about it. So I'll remind you once again that while the process is not linear, it's the expertise and judgment and knowledge of the implementation research team That's what drives the need for changes and also how changes are going to be made. It's not that we're not adhering to the protocol fidelity. It's not that we abandoned the protocol. We adapted the protocol based on the feedback we're receiving from the partners and based on the evidence we collect. So it's not random. It's not failure. It's actually better science. All right. So our summary for the second objective here is to talk about when and how PIs could handle those challenges associated with doing important research in a real life or real world setting. So how can we address those challenges that results from the changes without completely abandoning control and abandoning the study protocol? So you can continuously monitor team performance, identify early signs of failure, and be proactive in addressing them rather than waiting them to run their course and end up with failure to rescue. Allow different components of a project to progress at their own pace. So your technical side and your implementation may go much faster and much easier, but then it's going to stall, perhaps because your team is not ready to implement, or the team needs time to process why changes need to be made and maybe struggling psychologically. You can focus on deliverables, as Dr. Hewner was saying, focus on shared goal, focus on the vision and a shared agenda, and then adapt processes to align with that shared vision depending on the environment and environmental changes. And we can also, again, use evidence, not convenience. We're not changing the protocol because it's too time consuming to collect surveys. We're switching to phone calls because they may be faster and they may give us information that people are not willing to put in writing. They may be willing to disclose it to you personally and says, you know what, my boss just told me to ignore your project because we have other important financial priorities and our other contract paying us more money than you paying us for this project. Sorry. That's an important piece of information, but it's not necessarily, it's not going to come in the survey or in a written form. Okay. And you got it. So it's all of the above. All right. So what we can, if we sort of condense this information and think of how and what could be applied to other project and setting where you may be working, the things that come to my mind is that it's important to realize that one size, doesn't matter what size, is not going to fit all. That your team, even your team size, may change depending on the phase of your project. You may start with a bigger team and end up with a smaller team, or vice versa. And you need to be strategic and pragmatic about it. Just because that's what was written in the protocol, if it no longer fits with research priority, that's probably a reason to change it. And then when we're talking about partnerships with partners, and non-academic and non-clinical partners, or clinical partners, depending where you start, it's important to focus on real partnerships. That means bi-directional feedback, a real relationship as opposed to letters of support. Because if it was important enough to bring the partner, they probably have something very important to add that none of us on the research side probably have that perspective or experience or angle. And so focusing on the quality of those relationships and adjusting to accommodate partners' preferred modalities for communication, or frequency of communication, and sometimes timing becomes very, very important for research projects. And so staying flexible, but using evidence to make changes is another very important component, because once you decide that you're done and you want to publish, your reviewers are going to ask you, why? Why did you change? It's not a problem that you change, but tell us why. Because if you just abandon your idea, that's bad science. But if you use evidence and strategy to make necessary and strategic adaptation, that's good science. That's a publishable evidence, at least for an implementation journal. So thank you all very much for sticking with us through this. Thank you very much, Dr. Hewner, for sharing those very important insights. I'm happy to answer questions, and I really hope to see you folks in our next series in April when we talk about another different type of teamwork and team processes. So thank you all very much.